Hello, everyone, and welcome to today's PQA Quality Forum Webinar. My name is Amanda Ryan, and I am Director of Education here at PQA. Today's topic is implementing quality measures in payer pharmacy value-based arrangements. As usual, I would like to call your attention to three housekeeping items. First, you may notice that we are using a new platform for today's webinar. But as with previous quality forums, you can still submit questions during the presentation. This time you will use the Q&A feature that's located at the bottom of your screen. And then at the conclusion of the presentation, we will read and respond to as many questions as we have time for and address those questions to our speakers. Second, the webinar recording and the slide deck will be made available to PQA members within the week following the presentation, and that will be in the member resources section of the PQA website. And then lastly, I would like to encourage each of you to please complete the quick 1-minute survey that will appear at the conclusion of today's webinar. It is now my pleasure to introduce today's moderator. Lynn Pizzulo is the Senior Director of Quality Innovation for PQA, and she is responsible for identifying and prioritizing new measure concepts and overseeing the subsequent successful development, testing, and endorsement of new PQA measures. She is also the staff lead for PQA's work to build out a set of pharmacy quality measures. We are also joined today by 4 panelists for our presentation. First is Troy Trigstad. He is the Executive Director of CPESN USA, a clinically integrated network of community-based pharmacy networks. CPESN endeavors to improve the quality and effectiveness of enhanced services provided by participating pharmacies and align them with workflows and payment reform incentives of physicians and other healthcare providers. He is also Vice President of Pharmacy Provider Partnerships for Community Care of North Carolina, which provides wraparound population health management supports for nearly 2,000 primary care practices. Next is Trista Pfeifenberger, who is Vice President for Product Development and Customer Relationships at Community Care of North Carolina. She also has an adjunct consultative role with CPESN USA. She has previously held leadership positions in the pharmacy departments of Duke University Hospital and the University of North Carolina hospitals. Her impact on healthcare has been recognized by multiple organizations, including the North Carolina Association of Pharmacists and by the Triangle Business Journal. Todd Sorensen is Professor and Senior Executive Associate Dean at the College of Pharmacy, University of Minnesota, and Executive Director for the Alliance for Integrated Medication Management. His work concentrates on identifying strategies that facilitate clinical practice development and developing change management and leadership skills in student pharmacists, pharmacy residents, and practitioners. For over 20 years, his scholarly activities have focused on building collaboration with healthcare organizations to implement clinical strategies delivered by pharmacists that improve health outcomes. And finally, we are joined by Sam Anderegg, who is a pharmacist and the Chief Executive Officer at Docstation. Docstation is a software platform that helps pharmacists and payers collaborate to improve outcomes and lower costs for at-risk populations. Thanks to all of you for being here with us today. And with that, I will turn the floor over to Lynn.
Great, thanks so much, Amanda. And I'm super pleased to see all the participants that have joined us for today's webinar. Before I turn it over to our panelists, I'd like to just share on the next slide a little bit of information on an initiative that is part of our PQA Pharmacy Measure Development Action Plan. So, as we think about community pharmacies and they're continuing to expand their services, it's really important to develop the infrastructure to capture the value that these services bring to healthcare teams, including patients. So as part of that, establishing a set of measures is an important element, which is critical to demonstrating the value of these services and also, importantly, to ensure sustainability and spread. So to further inform a pharmacy measure set, PQA launched a series of summit meetings, which began last September in collaboration with the Community Pharmacy Foundation. And the goals of this initiative were to first identify and prioritize community pharmacy practice measure concepts that may be suitable for inclusion in value-based payment programs. And also, it's important for us to understand the feasibility. So as part of the project, and I'll share a little more on this in just a moment, was to evaluate and summarize the feasibility of implementing the measures in terms of their data collection and reporting, as well as highlighting additional data infrastructure needs. So as we move on to the next slide, so how did we accomplish this? We convened over 60 participants, and as with any of the groups that PQA convenes, we make sure that we have that multi-stakeholder perspective, so that we are really touching on all the critical elements and really informing the project with the various stakeholder perspectives. We convened the group over the course of several months through 5 virtual meetings. In that work, the group had worked to first identify a list of about 22 measure concepts that we went through a number of different meetings, including breakout sessions, between meeting surveys, and different ways of further prioritizing those concepts. And through all of that work, we landed on the top 10. We then went through a structured feasibility assessment. So we had adapted a standardized tool that is used by the National Quality Forum, and we engaged 25 different organizations to provide the perspective from the payer, the pharmacy, and also the system vendor perspectives. And they completed this assessment looking at 3 different domains. Data availability. So for each of the prioritized concepts, is the data element readily available, readily captured within the system? Data standardization. So if the data is captured, is the data element coded using a standardized terminology, like LOINC codes, for example? And then importantly, the data interoperability. So if the data is available, can it also be shared between entities that would be engaging in value-based arrangements? And then we also kind of took a deeper dive and had about 11 interviews, a subset of those organizations that completed the feasibility assessment, to really dig in and further understand the availability of the data and information that would be needed to understand on kind of a time horizon when could such measure concepts be launched into development. So as a result of all of that work, we took those top 10 concepts and kind of slotted them into these 3 different buckets based on their current feasibility state. So short term, meaning that these are the concepts that are closest to be ready to launch into development. And then mid and longer term buckets, meaning that additional work around the data infrastructure would be needed to be able to, excuse me, readily capture and report the data needed for the measures. And so as far as next steps for this work, the concepts that fall into that short-term bucket, we would be looking to launch new measure development groups to further flesh out the details around that. For the remainder of the concepts that fell into those mid and longer term buckets, what we're looking at doing is launching some pilot programs. And ideally for those pilots, we would be looking for the measure concepts to be implemented within value-based arrangements that would include pharmacies, payers, and system vendors to be able to collect and provide reporting on the data. And so with that, I, at this point, would like to turn it over to our panelists, where each will be sharing some of their experience implementing some of the measure concepts that were prioritized within our PQA-CPF collaborative. So first up is Trista and Troy. I'll turn it over to you.
Thank you, Lynn. Good afternoon, everyone. Really glad to be with you here today. As Lynn shared, CPESN USA and the collaborative, the summit that Lynn just described, CPSN, and Troy and I in particular were participants in that summit. And so we'd like to share with all of you today some of the same learnings that we shared with that group of summit participants over the last 6 months or so. Next slide, please. One of the first things that's probably worth mentioning is that CPSN USA has experience with dozens of value-based pharmacy service contracts. And those have all been over the past couple of years, and we have tested all of the performance measures listed on this slide. So you might notice at first glance that these measures have a very high degree of alignment with the measures that Lynn just described. And so again, we have some experience with trying to collect blood pressures, hemoglobin A1C, immunization, social determinants of health out of pharmacist documentation, and then using those as part of value-based contracts that community pharmacies were participating in. Along those lines, we gained experience around how hard it is to extract these various data elements from clinical documentation. You might imagine the cleanliness of the data, if you will, is not the same across all 6 of these measures. And that is largely, as Lynn described, why some of them might be easier to perhaps prioritize among PQA's measures versus those others that are put more into a longer term time horizon. Next slide, please. So I'll just be highlighting a few components of, again, our learnings across the several years of work, and probably first draw your attention to the point on the bottom of this slide. These value-based contracts are definitely not a unicorn. Over 100 of these types of contracts across the CPSN networks at this point in time, with over 50 of those programs being currently active. These programs are largely developed by leaders from those local CPESN networks, meeting with their health plan counterparts and really just trying to solution around problems that they have around disease state control, care gap closure, and how pharmacists can bring their services to the table to assist health plans with those. Clearly, there has to be a way to pull the data in order to measure the value. We have to have the data somewhere. And so for CPESN and all the programs we talk about today, the pharmacist electronic care plan, or the pharmacist e-care plan, was the preferred tool of clinical documentation and for exchanging that performance data with the health plans. In this case, the pharmacies were documenting across more than a dozen different pharmacy management systems. So from that standpoint, we did go through the process of really pulling the data out of lots of different systems. And so from that experience, I think it's highly relevant to the situation we're facing today in pharmacy and how these programs might be scalable. Next slide, please. In terms of the barriers that we experienced, I think some of the things that we observed are largely very similar with what our physician counterparts, hospitals, and other systems have gone through as they've gone to value-based agreements. And that is largely that really a lot of the effort around pulling the data out has to happen on the front end first, so that the providers doing the documentation on the front lines have to know exactly where to drop that hemoglobin A1C result, exactly where to drop their blood pressure result so that it can be extracted from the data. If they bury it in a free text SOAP note, for instance, that is going to be much more difficult to get out than a very structured data field, obviously, that's meant specifically for that type of data. So there's a lot of training. I will say that is not so much a barrier, but something to know, eyes wide open as you go into these types of programs, that is a very important part of it. Also, as I mentioned earlier, some of these things we ended up having to try to capture via free text because honestly, some of the demand for these types of measures from the health plan perspective, the demand is accelerating faster than a lot of the systems are in terms of capturing the documentation and the clinical documentation systems that the pharmacies utilize. Next slide, please. These programs overall, I think the great news is if they're going to be value-based programs, clearly they have to provide value back to the payer. Otherwise, we're not going to find health plans wanting to continue these types of relationships. They also need to provide value for the pharmacies and the patients that are served by them. So from that perspective, what we learned across these different programs is that we did find that through the pharmacist care plan, we were able to have clinical data available for reporting and monitoring of program results. So obviously that is the top line critical result that's worth reporting to this audience today. Certainly, we saw the ability for pharmacists to work across the care team with providers and other team members to close care gaps. I mean, clearly providers are medical providers that is, are incentivized to close some of the same care gaps around immunizations and, A1C tests and all of those types of things that pharmacists are. And so it does create nice models for team-based care. We were able to see improvement in some of those clinical measures, make referrals around social determinants of health so that patients could be connected to resources that they needed. And across all of this, we really saw high rates of patient engagement and improved connectivity between health plans and the providers, that the value-based programs really brought both groups to the table to actively talk about how things were going and how things could be improved. And I think the community pharmacies in particular found a lot of value in that dialogue in addition to the program. Next slide, please. So now putting on my current hat, as you probably could tell when I was introduced, I spent a lot of years with CPSN USA working on these exact programs, but I'm now helping a large physician CIN implement similar programs. And so I'm now looking at a lot of this work from the other side, in addition to continuing to provide consultative support to CPESN. And I'll tell you from where I sit today, it is really valuable to have multiple provider types contributing toward achievement of these types of quality measures, but we have to make sure that the care is coordinated, that it's not done away from or outside of the patient's primary care physician, that like Lynn described before, the data's got to be interoperable so that we can all know and see what's going on. We want those measure incentives to be aligned across different provider types. We don't want to be working against each other because incentives are misaligned. And finally, this is a big one, network status, where there are preferred networks, narrow networks, other things. There can be network status situations that prevent pharmacists and providers within an individual community from working together. And obviously, as it relates to this type of value-based agreement, that could be a big impediment. So at this point, I'd like to hand it over to my colleague, Troy Trigstad, to tell us a little bit more about our learnings.
Thanks, Trista. I'm going to have a sort of, that's the meat and potatoes of our experience at CPSN. I'm going to go to the next slide and provide sort of a high-level view of where we see things heading based on our experience and the environment that we're operating in. I would encourage everybody to download this report. If you Google Industry Trend Report from PQS, which is one of the family of companies of PQA, for those of you that didn't know, this is a really good report with a lot of really rich information about plans and providers and how-tos and IT and so on and so forth. And this graph really just stuck in my mind. My initial reaction when I saw this result was that the situation is flipped, and I'll describe what I mean by that here shortly. So Tristan and I both came from the patient-centered medical home side, ACOs, CINs, medical CINs, practice transformation for primary care, moved over to pharmacy, kind of brought that world to pharmacy, that those types of outcomes and value-based contract types of thinking and aggregating pharmacy providers. And I think we both would agree that past on the medical side is likely to be prologue on the pharmacy side. And all the same sort of beginnings and the trajectories and the challenges and the wins and the sequencing of events is happening a little bit more accelerated, I think, on the pharmacy side, but in the same sort of trajectory and sequence on the pharmacy side. And so why this is so striking to me is if we're looking at 2019, 2020 versus maybe 10 years ago or 15 years ago in pharmacy, what you're looking at here is plans. The majority of plans, likely or very likely, whatever, 23 and 46, 69, 70% roughly of plans say, yeah, if I can get a blood pressure and A1C result from a pharmacy, great. I think the marketplace is as such now where plans and other types of purchasers, self-funded folks, employers, folks don't really care where the outcomes come from anymore. They're just saying, I need a more efficient, effective, documented way of actually achieving outcomes and lower costs. And so I guess my message to the audience here is, if you go back 10 years ago, 15 years ago, it was sort of technology was out front, and then it was the providers, and the plans were way behind. There wasn't a lot of interest in the plans to be paying for services or value-based contracting or A1Cs or blood pressures or those types of things, right? And what's happened is that it's leapfrogged. And now what you have is the plans are out ahead of the providers. The providers are slowly marching on as they do with their practice transformation and their ethos, but the plans are out ahead, and now the technology is behind. And you saw the same phenomenon happen on the medical side, where the plans, pre-ACA, you had a little bit coming out of MMA of 2003, but at the turn of the century until about 2010, there was a little physician quality program here. There was a shared savings demonstration that the first one ever with Medicare that Tristan and I participated in at CCNC, but it was small test pilot, but really the plan universe wasn't completely on board. But yet there were a lot of systems being built, EMRs and other systems to collect data. And it was a little bit out front on that population management. And then medical practices kind of marched on, and then Affordable Care Act came along. And then what happened is the plans got out ahead, and the technology was, hey, I can't get my CCD out here, I can't go over there, and we end up having meaningful use and those types of trajectories. Same things happening on the pharmacy side. What was out ahead were technologies that said, hey, I'm going to put a box around MTM. Here's a platform, because the rest of the native systems of record aren't ready. The plans have what amounts to an unfunded mandate with MTM. And so we're going to create this space to do this stuff over there. Now, then the sort of marketplace evolves, and then we have this. Now what we need is liquidity of data. We need to be able to trade A1Cs and blood pressures and have an exchange of outcomes data. And there will need to be a sort of a technology catch up. And I'll describe that here in a little bit. Next slide. From a provider perspective, which is certainly our perspective, when you have this sort of cottage industry with a box around it called MTM, it's relevant, right? But for the vast majority of community pharmacy providers, it doesn't really affect their bottom line, right? It's nice, I need to do it, or maybe I get a penalty, a small penalty or whatever else over here, but my core business is still my core business. Once the marketplace grows, now as a provider, I say, look, I need a singular workflow here, because now this actually affects my bottom line. It affects a substantial number of my patients and the way that I practice pharmacy. And I can't have 6 different workflows in 6 different places. And so I think the plans are out ahead now. I think the notion of what does meaningful use look like for the pharmacy industry is going to be a really relevant conversation, certainly at PQA, probably PQS. And certainly we see the sausage factory for us on the bleeding edge of how this data gets to and fro. The biggest challenge that we see with all of the active programs we're involved with, whether that's improving PDC all the way to partial capitation or shared savings, upside downside risk, and everything in between, is getting actionable and accurate information from the purchaser to the provider at the point of care in workflow, and getting information at the point of care in workflow back to the purchaser. We all know this, not necessarily easy to do, but if you can pull that off, now you've really got something. And I think that's where we need to head. I think we're going to be $100 to $200 million MTM industry unless we get to this notion of outcomes marketplace, data liquidity, clearinghouses and exchanges for these value-based contracts. And it needs to be a $30 to $50 billion industry for community pharmacies to sustain itself. If you take the entire gross margin, netting out product for 60,000 pharmacies, it's $31 billion. We only need $31 billion of services to keep 60,000 pharmacies open, but that's a very small part, less than 1% of our total healthcare bill. Next slide. So if we were to prognosticate, and this could change, I could certainly find myself a month from now or a year from now saying, we got part of this wrong. But as we see it now, here are the 5 key components to a thriving $30 to $50 billion value-based contracting sector within pharmacy in the medium and the long run. The first is it's really, really expensive to administer these programs per unit of care delivery or per unit of outcome measurement. Candidly, we're not the most efficient outfit. There's probably more efficient outfits out there, but we feel like we've got pretty smart people, a lot of experience. We spend $15, $20, $40, $60, sometimes $100, $120 per transaction or unit of outcome, depending on what we're looking at, because we don't have the industrial strength tools and standards in place and machinery in place at scale to drive down that cost. And really, it needs to be about $5 less. I don't think it's 2 to 3 cents per telecom claim, but somewhere less than $5, probably in the $1.50 to $4.50 per transaction range is probably where this will go. And plenty of room if there's many more transactions than we have now for technology providers to thrive, but more in an exchange context than a platform context, probably. Matching purchaser networks with provider networks. The way we've organized pharmacy, Tristan, I can tell you, is a complete mismatch to the provider networks that purchasers want. Now, if you're looking at health systems or ACOs, they're looking for geographic, what's around them and who can they refer to or work with. If you're looking at employers, very similar, and they might have 6 or 7 places around the country. If you're looking at plans, again, most plans, even if they're national New York Stock Exchange listed plans, they all have state plans because everything's done at the state level or the regional level. And so, this idea that we've nationalized everything and sort of made it agnostic to the various medical trading areas and insurance product geographies and regulatory environments that are out there. And so that's going to have to be dealt with. Even if you're a chain, you're going to have to subset your chain with different types of activities and different leads for different programs that are out there on the medical side. Provider status and fee schedule. I think a lot of folks think, oh, we're just going to skip fee for service and go straight to value-based contracting. That's not the case. I mean, you can be an HMO, but I don't think pharmacies are going to be an HMO. So even on the shared savings types of programs with Medicare or what we see coming through Medicare Advantage plans with physician CINs, you're still billing 99214s. There has to be a base. I do something, I get paid for that something. And then depending on how I perform, I might get a higher rate, a lower rate, a bonus. I might engage in some shared savings with 25% of the upside or 15% of the downside, et cetera. So we still have to seek that idea of pharmacies providing services and getting paid for it. The value that you bring may change the total remuneration though. We absolutely have to reduce provider workflow that reduces heat loss. If you've ever worked in a pharmacy, those of you who work in a pharmacy out there, it's absolutely possible to be engaging with a patient, to have an effect, great moments in time as you're dispensing. You can be very effective very quickly. You cannot spend as a pharmacist practitioner or as a pharmacy owner, $30 on pharmacist time, and then $40 to log in, administer, bill, track it down, follow up on it, and get paid $50. That doesn't work. That's what the world looks like right now. So we have to reduce this administrative workflow heat loss and also care delivery heat loss so that I'm getting $50 for spending $30 of my intervention time, and maybe it's $5 for that administration on my side. And that's all about workflow in the pharmacy. And then thinking in terms of that flip, again, that IT is the essential coenzyme. It's not the thing, it's what makes the thing better. The thing is a healthcare professional providing a service to a patient and perhaps their caregivers. And so that's what will make the industry bigger, go from 100 and 200 million to 30 to $50 billion industry, is that you get actual providers in the position where they can work with the most of their patients in an efficient way. And then the technology wraparounds have a lot more units at a lower margin. Next slide. And I think Trista I wanted to leave you with real world. These are 2 of the 54 that are active right now, just to give you a flavor of what's out there that looks a lot like the medical side. So this is one Medicaid MCO that said, hey, here's A1Cs. We're going to do a per member per month, but we're going to base that per member per month on the ability to deliver the services. We're going to require everything in the care plan. We want that information. It's helpful for our care management purposes. It's helpful for our quality. It's helpful for our narrative with the state, who's the purchaser. And the care plan is the vehicle by which you transmit that information. The next one is even more aggressive. Next slide as an example. Basically, this plan said, we don't really care how you do it. We don't even want the data. We're just going to look at our claims. We'll pay you a modest per member per month, but we want you to win when we win, and it's 65% of the shared savings from this intervention that go to the network. So these are more on the forward-leaning or bleeding edge of these types of contracts, but I'll tell you, and Trista, I think will agree with me, the appetite for these types of arrangements grows and grows. And I would say on the plan side, they're getting more and more efficient about how to get these types of arrangements through their companies and actually execute them with lower costs. Having said that, it's still really early in the game. And I think there's no better place than PQA and probably PQS as well to help us mature as an industry. That's all I got, Lynn.
Thanks, Troy. So at this point, we will move on to Todd Sorensen.
All right, thank you, Lynn. So in this part of the presentation today, it'll be a bit different than what Trista and Troy just presented, and that being a high-level overview on national in scope. This is specifically looking at a payer-provider partnership here in Minnesota, facilitated through Health Partners Health Plan, and our experience trying to create practitioner engagement, which would ultimately lead to beneficiary engagement in this program. Next slide, please. So a bit of the history of Health Partners and medication therapy management. First of all, if you look on the far right side, Health Partners makes a point, and every time that they speak about this, that what they are talking about here is different than what we commonly think about MTM as it relates to Medicare Part D programs. Over the course of this presentation and the intervention that was involved in what is considered to bring value to health plans, it's a comprehensive medication management service model. Full care, all medication-related needs of the patients provided and served by the pharmacists. But this did start back in 2006 with the Medicare Part D program, and Health Partners being a Part D plan started offering this program as a part of the Part D program, but eventually came to believe, also at that same time in 2006, Minnesota Medicaid started providing payment for medication therapy management services, although in that case, more closely aligned with the comprehensive medication management service model. So in 2010, Health Partners said, well, if we're doing this with our Medicaid patients, if we're doing this with some of our Medicare beneficiaries, why are we not doing this with our commercial business? And moved to adopt this model into all three books of business across Health Partners. 2015, prior to that, it was largely fee for service. In 2015, they added medication management services into their Partners in Excellence program. Partners in Excellence is the value-based program across all of Health Partners, medicine, pharmacy, dentistry. They all have a component of Partners in Excellence. And one of the things that I would highlight here is that within pharmacy, this particular part of the Partners in Excellence program that we're talking about is specific to this comprehensive medication management model. Health Partners does also have in its traditional pharmacy network related to medication access, a Partners in Excellence program that addresses things like adherence metrics and some of the traditional things that are done. That is managed as a separate value-based program. This one is specifically a clinical care service where they really expect to see the impact on their medical benefit. And then in 2019, the Partners in Excellence program, as it first started out, it was just focused on beneficiary engagement. It was expanded to include clinical outcome metrics. The history and the sense of value perceived at Health Partners comes from internal analyses that they've done over the years. This is just a snapshot of some of the internal analyses that they've done. When they look at diabetes control within those who have engaged with a pharmacist versus those who have not, you see a significant difference in diabetes control. Same thing with optimal blood pressure control. These numbers, I'll point out optimal diabetes control. So of course, that's more than just A1C. It's A1C, blood pressure control, statin use, aspirin use, all included in that optimal diabetes measure. Experience, when patients engaged in this service, they were willing to recommend it and strongly agreed that the pharmacist helped them feel more confident in managing their medications. And from the health plan perspective, from a cost standpoint, they did see a return in value. 3-to-1 ROI across the commercially insured members. When they segment that population and look at specifically at some of their highest utilizing, most complex beneficiaries, they see an ROI of up to 11 to 12 to 1. And that has been measured internally on two separate types of analyses. So go to the next slide, please. Health Partners has perceived that if they can engage a pharmacy network, pharmacy providers in this service, it will generate a return and a value back to Health Partners health plan. The challenge is overall engagement was low. Low both in terms of their beneficiaries and in the number of providers within the region that are actually providing the service, contracted and delivering the service. So largely, the service was being delivered by pharmacists based in health systems within the market, the region that Health Partners operates in. Most of our integrated health systems have pharmacists in their primary care clinics, and that was probably representing 90% or more of the engagement in this program. To be able to reach all of their beneficiaries, couldn't rely on that only. So Health Partners really intended to create a focus on engaging community pharmacists in this. Some were contracted, but were not actually delivering services. When you would look at the difference between the network membership and the claims being submitted. And that is the challenge that the Slice of Pie program, so Pie being the overall value-based program, Slice of Pie was taking a portion of the Partners in Excellence program focused on comprehensive medication management and engaging community pharmacists in this program. Next slide, please. The value-based program, the Partners in Excellence for this particular component is structured with two levels. The first level is reaching silver performance. The participants in the network achieve clinical benchmarks. Now, one of the things that I think is important part of the Health Partner story in this case is realizing that there is a learning curve that the provider network needs to engage in. And so they did not create the bar too high to begin with. So at this moment in time, it's not actually the achievement of clinical benchmarks. It's starting with just the submission of the clinical data. Eventually, as the systems come in place, as the providers become more comfortable with this, as the relationships to gather that data are created, it'll eventually move to true outcome measurement. But at this point in time, participation in this program is really just submitting the data at this point. If you meet that benchmark on clinical data submission, then you are qualified for gold performance level, higher level of bonus payment, and that is then achieving clinical engagement. A percentage of the beneficiaries that have been attributed to the practice have actually received the service. Next slide, please. A number of things that Health Partners has done to try to encourage engagement and support success in the program. And again, I think overall, one of the messages that I wanted to share from this is how this payer-provider partnership grew and the different roles that different groups are playing or are challenged by it, because it really has been a back and forth between the plan and the providers to find a way to generate value in return to both parties. Just offering a payment program for these clinical services was not enough to move the needle. It did not create any engagement. It did not create the level of outreach to beneficiaries to return back to the Health Partners. So a number of things have been done to try to support that. First is continuity of care document. Of course, that's required, but there's no proprietary platform required for that. That can be submitted through a generic technology process. Any provider in the network should be able to submit that through vendors that are already in place, to not require new vendor relationship. Patient registries are created and a beneficiary portal for attribution and monthly reporting of the practice's progress towards its targets, overall measure results, and patient level detail provided on a regular basis to help them see where they are, and the measurement overall for the Partners in Excellence program is done on a biannual basis. Next slide, please. Now, what this 18-month experience that we were just wrapping up entailed was all of that was in place before, but we didn't have the engagement and making the impact that was necessary. So added into that system, implementation support structures to try to bring the two communities along together. Some of those implementation tools, fidelity to the patient care process. As I mentioned, there is a certain service that Health Partners is purchasing in this case. And it wasn't necessarily clear whether or not that was the service that was being delivered. And when we do the evaluation on this, an important component to think about is the unit of intervention here is not a pharmacist. The unit of intervention is the service provided by a pharmacist. And so we needed to know what service is being provided so that it can be replicated and we can ensure similar outcomes and similar value returned as the program expands and reaches new providers. So we went through a fidelity assessment process and a training process for those pharmacists who were not demonstrating fidelity to the patient care process. We created learning and action community, engaging all of the groups. There was 12 different community pharmacy organizations that represents multiple pharmacies and 30 to 40 pharmacists that were directly engaged in this work. Engage them in a community where they all could learn and share together rather than operating in their own silos. And that included monthly webinars, programs, live events prior to COVID, and coaching. Each one of these practice sites had an improvement coach, an implementation coach assigned to them, and they had monthly meetings with their coaches. And then part of that coaching process to help them develop and think about the practice management system. How are they going to build the process of integrating this into the rest of their organizational work? Next slide, please. And we can move on to the next slide. So some of the challenges and barriers, and these are things that we've captured through focus groups, interviews with pharmacy managers, frontline pharmacists, and the health plan leaders. First thing was, we thought that because many of these entities were already registered as a provider with health partners, that we could start at a certain level. We quickly found that we needed to come back at least 2 steps from where we thought we might be ready to start with this process, because many of the participants did not understand credentialing processes. They did not understand how to link the IT infrastructure together for claim submission and CCDs. We didn't have the necessary fidelity level of service. And one of the things that we did not fully address yet is access to clinical data. So we really had to work through each of these items. Much of this, the credentialing processes, the way to submit claims, the way to submit CCDs, was all available on the Health Partners website. Health Partners thought that they had done what they needed to do in that case. It wasn't enough. We actually had to rely on coaches to individually help the practitioners and these organizations understand how to establish their way of connecting with and communicating with the health plan. It's very foreign to many of these groups. And again, if a health plan is going to engage in this, realizing that there's going to have to be this learning curve that you're going to have to actually actively engage the practitioners in, rather than just putting out the shingle and saying, here's an opportunity, take advantage of it. So if we move on to the next slide. That data component, when we looked at fidelity, not necessarily to the service, but fidelity to the PI program, submission of those elements that were required for measurement for value-based payment. On the diabetes program fidelity side, we can see that 12% of the attributed patients had a blood pressure, smoking status, and A1C reported. Now the slide says not assessed. Actually, I should change that. That's not actually the right way to reflect this, because in the denominator here, the 88%, those are all attributed patients. Those are not necessarily all beneficiaries who receive the service. Those who receive the service is a smaller subset. But of those that were attributed, and again, from the planned value, only 12% had this fidelity to these elements. And on the CVD side, you can see a little bit better, but still far less than what was hoped. Next slide, please. Other things that we identified in these interviews and focus groups was, first of all, competition for time. What we heard is that there was often a disconnect between what the pharmacists on the front line felt like they should be spending their time doing and what managers in the pharmacies thought they should spend their time doing. Some of that was between dispensing work, but what we really found was that a lot of it was competition within different clinical programs. We heard from pharmacists said, I want to spend more time in this health partners program because I feel like I'm making a real difference. I'm not just checking boxes as I might be over in this other clinical program. But that wasn't necessarily where the revenue stream was perceived to be. And it created a dissonance within the organizations about how to meet the expectations of the various programs that they were participating in. Prescriber collaboration, we need more time to work with the sites to do this. Thinking back to one of the slides that Troy and Trista had, this is a case where both the medical provider and the pharmacy provider can win. It doesn't matter who gets these beneficiaries to goal, both of those entities are going to win in the pay for performance program. The pharmacist had not become comfortable with yet and figured out a way to leverage that status with the providers in their community and develop collaborations, because it wasn't a zero-sum game. They can both win if they work together, share information, share care. They'll both ultimately receive a fiscal benefit from health partners. Patient responsiveness, we'll look at that a little bit more. And of course, COVID-19 had some impact on that. And I mentioned the organizational expectations. So next slide, looking at the value produced. The question on that remains open at this point. Some of the analysis is not done yet. We are going to be doing a return on investment analysis, but are unable to do that until early 2022. But if we just look at within the diabetes cohort as an example, there was 171 beneficiaries receiving an initial assessment. Or sorry, it was 171 plus the 25. 87% of them were already at goal. That was either a patient self-reported level or an actual level that was acquired. And you see that same thing pass through here in the diabetes cohort and the CVD cohort on blood pressure levels. So where we need to go is looking at, these were all attributed patients, but many of them were at goal, or at least the cohort was different. Those that the pharmacist reached were already at goal. So we needed to find a better way to leverage data within the practice to identify those patients who are at goal. It's going to be difficult to show value back to the health plan if your patient population that you're seeing is largely already at goal and we're not showing a difference. Go to the next slide. We wondered whether or not the cohort that had received the service was truly different than those who hadn't, or if it was just some sort of other factor coming into play. But here you can see there is a significant difference between those individuals that have received the service versus those who were not. Lower medication count. This is targeted medications. This isn't their whole medication list. Doesn't include OTCs. Doesn't include all prescription medications. These health partners in their risk assessment targets certain medications, but yet lower number in the engaged, lower risk score, and a lower MTM risk cutoff. So we weren't yet getting to the right population within an attributed group. Next slide, please. And so that was a challenge for the pharmacist. But the good news on this is, of the attributed beneficiaries, this group of practitioners achieved a much higher engagement level than the rest of the network, which would have also included the practitioners and health systems. 42.8% of the assigned members were engaged in a service. So it's not so much that we can't create the engagement, it's that we need to create the engagement with a refined population to truly deliver value. And I'm going to end with the last slide, which if anybody's interested in additional information related to this project, there's a number of places you can go. We've run a blog over the last 18 months to share some of our experience, publications, both out and coming soon. Sam, over to you.
Thanks, Todd. Hey, everybody. I am here to talk to you about the technology side of implementing these value-based models. Before I jump into that, I just want to highlight, I was listening pretty closely, and maybe it's just because I'm so entrenched in this, but there's an amazing amount of consistency between the messages that, Trista and Troy gave, and then Todd as well. We're all working towards the same thing. There are similar barriers regardless of which health plan you are, what type of pharmacy you are, and what kind of technology vendor you are. So I'm here to give you a little taste of what we're up to and how we're making this. I think the role of technology here is to make all these inefficient processes much more efficient so we can get down to business. And that is taking care of patients, improving outcomes, and decreasing costs. You can go to the next slide. So Docstation, think about us as we're a software platform. We help health plans and pharmacists collaborate to provide care, keep patients healthy, improve outcomes, and decrease cost. The way we do that, pharmacists use Docstation as a practice management system, or effectively their own version of the electronic health record. Health plans partner with Docstation to design and deploy turnkey value-based programs. Go to the next slide. So of the 10 measures that came out of the summit recommendations, for all intents and purposes, we're ready to deploy 9 of those 10 measures. Now, they're not validated and tested and have PQA stamp of approval on them, but that's the whole point of this and accelerating this. We need to get these measures into pilots, we need to test them, we need to validate them so that we can tie payment to them across the entire industry. Now, of those 10, 2 of those measures at the top there, so blood pressure at goal, hemoglobin A1C at goal, are actively running in programs. That means payment is tied to a pharmacist and pharmacy's ability to impact these measures. 7 out of the 10 are just waiting for a health plan to come along and say, yep, those measures look very important to us in our plan population. We want to run a pilot on them. So we're ready to go on 7 of the 10, 2 are actively in place. You can go to the next slide. So what does that program design look like? So if you're a health plan, you're walking in, you want to pilot or test one of these value-based programs, you've got a measure library to select from, right? And you can choose measures that you simply just want to track and monitor. So those being display measures. And then you've got the active measures, or ones that are tied directly to payment. So pharmacies and pharmacists are incentivized to perform well on these measures, and when they do, they get paid more. You go to the next slide. So the 3 kind of key points that I'm going to go over here that are going to be generalized to any vendor, not just us, are data capture, data reporting, and implementation and scaling. So the first is data capture. Simply, we need to be able to capture the clinical data, assessment data that is not available in claims at the point of care, so that we can use it to calculate measures, plain and simple. You can go to the next slide. I'll highlight some need to haves and nice to have. So that first one there is just capturing the data. The second is you have to have payment incentives, right? We talked a lot about ROI and the pharmacist needing some sort of incentive to engage. Well, it comes down to finances, right? Pharmacists want to transform, they want to do more clinical services, and if money's right, they will engage. So how do we make that easier? We make things more efficient. So claims integration, we've got this rich data set available at the plan level. If shared with pharmacists, it makes their job easier. It reduces the administrative burden, which increases the ROI at the pharmacy level. It's also nice to have patient targeting. As Todd was mentioning earlier, how do I prioritize my panel of patients? Who do I focus on first? Who needs me the most? And that's just looking at patients that are either incredibly high risk, like going to the hospital a lot, or backing it into these measures, right? Which patients are in the denominator and not in the numerator? And how can I close these gaps? So how can technology kind of direct me as a pharmacist to utilize my time as effectively as possible? Streamline documentation, we talked about that as well. We can't spend a half hour, 40 minutes documenting an encounter after it occurred. How do we do that quickly and easily so that data is captured, it's reported so I can see my performance, and I can run a business? Next is workflow integration. Pharmacists are the most accessible healthcare provider in America. We need to leverage those interactions with the patient as best as possible. So when a patient comes in to pick a prescription, I need to be able to quickly open up the patient's profile and see what else I can address at that opportune time. And last is an attribution mechanism. So if you're a health plan, you got 100,000 patients, which group of patients are assigned to this pharmacy, and therefore dictating responsibility and accountability, particularly towards those measures. Next slide. The second big group after data capture is data reporting. So ideal state is, we want to have real-time dashboards that from the plan's perspective, I can monitor how effective my programs are running in real time. And I can see which pharmacies and pharmacists are performing out on the front end of the network, and which ones are kind of lagging behind. That's ideal state, but that's not what you need to just get one of these programs up and running. Go to the next slide. So what you need to have is you just have to have a way to get the data that's being captured at the pharmacy out of the system. And you have to have a safe mechanism to transfer that data. And it could be as rudimentary as a secure FTP folder. And it could be as sophisticated as an API. You also need to be able to aggregate eligibility files, claims, both pharmacy and medical, and that clinical data together. Now, it seems relatively simple, but a lot of times there's, it's incredibly complex. So you need to have that ability to actually calculate the measure. And you need to have the ability to calculate performance at the pharmacy level. And when you do that, that dictates you can apply kind of the payment model to that and determine what the pharmacy will actually get paid. Some nice to haves here are, it's nice to have dispensing data. Great example is in, adherence measures or immunization measures. If a patient, is cash pay, for example, it's not showing up in claims. So how do we get a more accurate picture of performance so the pharmacies can be paid appropriately and the plan doesn't get penalized inappropriately when they're reporting that data to, Medicare, Medicaid, et cetera. Nice again to have performance data. If I'm a pharmacist and I'm closing a gap in care, I'm documenting a blood pressure that's finally at goal. I've been working with them for 6 months. I want to be able to have that immediate feedback in my dashboard to say, hey, I did this, my performance is captured, and I'm going to get paid to do this. Incredibly helpful to have that tight feedback loop. And the same with the payment automation. How do I get pharmacists and pharmacies paid timely so that reward is there, which incentivizes me to go out the next month and do even better? Go to the next slide. So this is what we're working towards, right? This kind of value-based program ecosystem, data ecosystem, where we've got plan supply data on the top left there, eligibility, medical, and pharmacy claims. Stuff already exists. We need to aggregate that and combine it with the clinical and assessment data that we need to calculate these measures. And if we have those two things, we should ideally be able to report each measure at the plan level, at the pharmacy level, and at the patient level in close to real time. Go to the next slide. Just a couple notes here at the end on implementation scale. Troy was talking about the market being maybe 100 million, 200 million. How do we make it the new normal for pharmacy? How do we make clinical practice kind of our bread and butter moving forward? Well, it's got to be inexpensive to initiate, right? Budgets can be tight, and oftentimes these programs are seen as a little bit more innovative. Innovation budgets, hard to come by sometimes. So how do we pilot these with a very small or targeted population, a subset, get some data back, and be able to kind of make a business case for the organization to try to scale this to larger patient populations or other sides of the business of your health plan. Second is you got to be able to implement quickly, right? We don't want to spend too much time figuring out the logistics of how to do this. So how do we go from 0 to 100 miles an hour in 6 weeks or less? And lastly, as things scale, this is more on the longer term nature. As these things really take off and we're running program for Medicare patients, Medicaid patients, commercial patients, as a health plan, I can't navigate that or use so many different vendors. That's what the pharmacies are struggling with. So we've got to be able to streamline these programs and be able to manage them kind of all within the same ecosystem or environment to make things more efficient as we move forward. I'll stop there. Turn it back to you, Lynn.
Great, thanks so much, Sam. And thank you to Trista, Troy, Todd, and again, Sam, our panelists were really fantastic this afternoon. I'm sure our participants have lots of takeaways to bring back and think about how they can implement some of these best practices in the work that they are focused on with value-based arrangements. We are running short on time, so rather than go to live Q&A, I just want to note that each of our panelists has typed in responses to any of the questions that have come in during today's webinar. So with that, I will hand it back over to Amanda to share some additional highlights and wrap up today's session.
All right, thank you so much, Lynn, and I echo your thanks to our panelists for joining us today. Very informative discussion, so thank you so much. We do have several events that are coming up soon here at PQA. First is our third quarter stakeholder advisory meeting. That is going to be held on Wednesday, August the 25th from 1 to 2 p.m. Eastern Time. This is a members only staff hosted meeting, and we will share measure development and maintenance updates along with engagement opportunities. The registration link is available to PQA members in the member resources library section of the PQA website, or please do reach out to us if you've got any questions about that meeting. Next, the PQA Leadership Summit is going to be November 10th and 11th in Arlington, Virginia. This year's summit will be a hands-on meeting where key leaders from PQA's member organizations will engage in a series of interactive discussions around the implementation, the feasibility, and the completeness of Blueprint PQA 2025. Key contacts from PQA member organizations did receive invitations to this event earlier this week. And also, if you are interested in sponsorship opportunities, please do contact us, reach out to any one of us, or you can email sponsorship@pqaalliance.org. And then finally, on the next slide, we have a bonus quality forum for you. We will have a second quality forum this month of August. That will be on the 19th. During that forum, we will hear from Anthony Minetti from Bell Pharmacy in Camden, New Jersey. Bell Pharmacy is the recipient of this year's Community Pharmacy Innovation and Quality Award in the pharmacy category. We did announce those winners back in May at the PQA annual meeting in partnership with the Community Pharmacy Foundation. We will hear from Anthony about Bell Pharmacy's innovative pharmacy-based PrEP clinic model that serves people who are at risk for HIV. And then finally, I would like to remind all attendees to please share your feedback with us in the survey that launches immediately following this webinar. And as a final reminder, the webinar recording and the slides will be available on the PQA website within about a week. Thank you all so much for attending, and have a great rest of your day.